You referenced a survey about what percentage of OBGYNs actually perform induced abortions. And, I think there have been about 3 studies, maybe even more now, that really show that a small minority of OBGYNs have induced abortion as part of their practice. I always think about the cognitive dissonance it would take to walk into a room and be really excited, maybe with a couple who've experienced infertility, that they have a positive pregnancy test, and then go in the very next room and write a prescription for mifepristone and misoprostol to end that person's life. Welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, APLOG. On this podcast, we bring on experts to provide insights to support you as a medical professional in your life-affirming practice and career. I'm your host today, Dr. Susan Bane. I've practiced obstetrics and gynecology for over 25 years, and I serve as the vice chair for APLOG's board of directors. So I'm joined today by Dr. Ingrid Skop. Dr. Skop has been practicing as a board-certified obstetrician for over 30 years. Dr. Skop is a fellow of the American College of Obstetrics and Gynecology and a board member at APLOG. She currently practices with an OB hospitalist group and is vice president and director of medical affairs for the Charlotte Leisure Institute. She serves as medical director for AWC Centers in San Antonio, Texas. She's on the medical advisory board of Save the Storks, on the board of Seton Home Maternity Shelter, and as a member of the Texas Maternal Morbidity and Mortality Review Committee. Dr. Skop, thank you so much for joining us today.
Thanks, Susan. It's great to be with you today.
So today we're going to be discussing the complex family planning, or CFP, subspecialty within the field of obstetrics and gynecology. It was created in 2019 by the American Council for Graduate Medical Education, ACGME, for the American Board of Obstetrics and Gynecology, or ABOG. So according to the Society of Family Planning, the purpose of the fellowship is to train physicians to be leaders in the field of complex abortion and contraception through advanced clinical practice, research, and training. So let's start the conversation, Dr. Skop. Can you share with us a little bit more about this specialty? What is a CFP fellow and how this all got started?
Yeah, I think you've heard the term, the long march through the institutions. And it turns out that unbeknownst to most of us, there was a long march through the institution of obstetrics and gynecology. Even prior to Roe, back in the 1960s, many obstetricians wanted legalized abortion. They were doing abortions, they were just doing it illegally. 90% of abortions at that time were performed by physicians. They didn't want to get in trouble. They had eugenic motivations for what they did. There were some women they felt should not be having babies, young women, poor women, minority women. And so as we saw, they were influential. They were able to get the courts to overturn the abortion laws in Roe v. Wade. And so for about 20 years, they were merrily on their way doing abortions as they wanted to do legally. But in the 90s, they began to recognize we have a problem. Those that had driven the legalization of abortion were starting to get old. They were starting to retire. And it turns out that young obstetricians weren't interested in doing abortions. We know why we go into this practice of medicine. We love both of our patients, and so doctors really did not want to participate in that process. And so it appears that at that time a plan was set in motion. The first phase of the plan in 1991 was the creation of the Fellowship in Family Planning. This started at the University of California, San Francisco, where so many pro-abortion ideas start, with the Bixby Center for Global Reproductive Health. And they created this Fellowship in Family Planning. It was funded by very wealthy pro-abortion population control funders like Warren Buffett and others. So initially they began pumping out abortion advocates, and they report that 80% of them now work in academic institutions. So we see the influx of this pro-abortion ideology into the medical schools and residencies. In 1996, ACGME, which you mentioned earlier, decided that these residency programs needed to provide an opportunity for abortion training. And so they created what was called opt-in training. So at that time, what that meant was, as many of us went through in this era, you didn't have to do an abortion, but if you wanted to learn how to do abortions, the programs were required to give you that opportunity. In 1999, the next step came. This was the Ryan Residency Training Programs. So these were within the residencies. There are now 75 of these that are active. So again, very active, promoting the trend of abortion and really, causing the residents to become pro-choice. And this has also been very successful. Those funds that I mentioned from the wealthy donors were paying the salaries of these FFP-associated physicians in the programs. So of course the programs were happy to have someone pay the salary for someone else to work in the institution. And along this time, kind of unrelated, but not really, who knows what drove this, but the FDA approved the abortion drug mifepristone in 2000. And again, this was another way of dealing with the staffing problems. They could not find enough abortionists to do surgical abortions. In 2004, the Society of Family Planning began, and they have a peer-reviewed journal that most are familiar with called Contraception. It's ironic, because the journal does not focus very much on preventing pregnancy. It seems to be highly focused on ending pregnancy. In 2018, the ACGME made a change, and they said, instead of opt-in, we now need to make these programs opt-out. So that means that everybody it's going to be assumed that they'll train in abortion, and only if they're brave enough to stand up to that power imbalance as an intern and say, I don't want to do this, are the students allowed to opt out. And then, of course, the following year is when the Complex Family Planning Fellowship was approved by the American Board of Obstetrics and Gynecology. And presumably, because it is now a certified subspecialty, every residency program will be required to have staff and training in this. As you mentioned, they talk about doing things like complex miscarriage management, complicated pregnancies, but we know we've had maternal fetal medicine specialists that have helped us with that for decades. They talk about performing contraceptive technology research, but when's the last time we've seen a novel new contraception enter the market? So we realize that it's only about abortion. It's about teaching these dangerous, destructive, painful dismemberment D&E procedures, and it's about creating abortion advocates who are then going out into the public. They're publishing many studies in the peer-reviewed literature, overwhelming the system really with abortion ideology.
Yeah, thank you for sharing that history. I mean, I was training in the 90s and completely unaware this was happening. And it was that long march. And we're now at a place where complex family planning is part of academic medicine, even though the focus is really only on one of our two patients. And it doesn't even seem like the second patient, the baby, has even an acknowledgement as a patient in this fellowship. So when you think about how this fellowship impacts pro-life professionals, those of us who practice life-affirming medicine, whether it's the next generation, medical students and residents, or future generations, current generations too, what are your thoughts on how this impacts our profession?
Well, it's clearly damaging our profession. We've left, obviously APLOG has not, but so many obstetricians have left the two-patient paradigm, where we have the blessing and the responsibility of caring for two patients and needing to consider both of their needs. Unfortunately, we've seen since the Dobbs decision this narrative that abortion must be a tool in the toolkit of an obstetrician, that somehow quality care can't be provided without providing abortions. But I think that we all recognize that that's false. In 30 years of practice and 5,000 babies, I've never needed to provide a direct abortion. So it's not something that is needed, but this ideology, unfortunately, I think influences too many of our peers, as we saw by the confusion and fear that so many obstetricians expressed after the Dobbs decision, that somehow that if they couldn't provide abortions, they couldn't provide good care. But going back to the medical students and just the pro-life residents, you know, it's the case that very few obstetricians do abortions. A 2018 peer-reviewed study demonstrated that only 7% said that they would do an abortion in their private practice. So again, not necessary, but forcing these young training doctors through the opt-out, again, means that they're going to have to stand up, be brave in the face of a power imbalance, and say, I don't want to do this. They'll be intimidated, there'll be coercion, in many cases retaliation, sometimes professional ostracism. We've heard stories of residents being forced to create their own alternative programs, undergo values clarification, sometimes given the worst call in vacation assignments, and overall just being forced to endure this harassment and scorn that comes from asserting your beliefs. And then further down the line, this is stopping pro-life medical students from going into obstetrics as a specialty at all. I've talked to many of these students. They're convinced they will either be forced to violate their conscience or be unable to complete their training if they pursue an OBGYN residency. We also know that many of these programs are actively screening out pro-life students. So this is a problem for our profession going forward, that fewer and fewer doctors who value human life of the unborn are even allowed to enter and train in the profession. And it works. A report from the Bixby Center documented that about a third of the residents who initially chose to opt out eventually performed an abortion during their residency. And of these, 16% said that they now planned to provide abortion in their practice. So again, violating the conscience is, in many cases, does lead to a conscience that is numbed to life and then is willing to accept abortion.
Yeah. You know, I think what this specialty has also done is it's so much trying to normalize the direct and intentional killing of one of our patients, an innocent human being, as part of medicine. And if we know the purpose of medicine is health and healing, there's no place for that in medicine. But, you know, I was recently looking at the American Board of OBGYN, ABOG, which is a certifying body that certifies us as board-certified OBGYNs, which are often connected to the ability to get hospital privileges, credentials, that represents all of us. They just started a podcast, and their very first one, they chose to talk about complex family planning specialty. Of all the things they could have talked about on their Women's Health Matters podcast, that was what they talked about. And one of the individuals there actually made this statement, one of the guests, that contraception, abortion, miscarriage, and ectopic care are bread and butter for gynecologists. Well, bread and butter for my last, 20 plus years as an OBGYN, I think I'm on year 28 now, included talking about prevention of pregnancy, the contraception piece, miscarriage and ectopic, but it didn't have abortion. I, like you, have been able to practice and not do a direct abortion. But respond to that statement that bread and butter for an OBGYN is supposed to include induced abortion.
Well, obviously this person is an ideologue and really is denying the science that is involved here. I mean, we are professional healthcare providers. We must provide the best care that we can to each of our patients. Actively ending the life of one of our patients is the antithesis of what healthcare means. it's just really a upside down world that we've entered. I think we've seen it with all of the euphemisms, reproductive justice, etc. They won't even say the word in so many circumstances because they recognize that the American public we know, but again, it goes to numbing the conscience. It's sort of an Orwellian situation that we're in where they feel like if they can just repeat these narratives and euphemisms enough, that somehow they will win the day. I don't think they will. I think that really the first step is what we're doing here, making obstetricians aware of this problem, of the way that our profession has been corrupted, so that no longer is the value of human life the primary goal. But in so many of these situations, I think it's social engineering concerns, eugenics, you name it, but it's not about the well-being of either of our patients. And again, as you know, I've spent my last several years concentrating on how much this action harms women. That's not being acknowledged at all in this complex family planning conversation. And again, what is the procedure they're teaching? It's the late abortions. It's the dangerous abortions that the CDC tells us are 76 times as likely to kill a woman when she has a D&E after viability compared to an earlier abortion. So again, absolutely the opposite of what we should be focusing on as obstetricians.
So let's turn to thinking about the ACGME requirement for abortion training to be opt-out now. So basically, when we trained, it was opt-in. You could learn. Now it is opt-out. You're supposed to do it because as actually this chair said in the podcast I referenced, it's bread and butter to do this, to do abortions. But what is the connection between the Complex Family Planning Fellowship and that ACGME requirement for abortion training to be opt-out only?
Well, I think it's important to recognize that the leadership of so many of these mainstream medical organizations have been overlapping and have been pro-abortion for years, as I described. So we see this with ABOG, we see this with ACOG. Those two organizations seem to have a very tight, intricate pro-abortion relationship. And of course, apparently the ACGME feels the same way. So this is being driven not from the ground, not from the clinicians who see a, quote, need for this. This is being driven by the ideology of the leadership of virtually all of our professional medical organizations. And there's something to note in that there's a legal conflict here. The Coates-Snow Amendment is from the federal government, says that states and local governments cannot receive federal money if they're violating the conscience of residents or obstetricians by forcing them to perform abortions. And yet at the same time, the ACGME has the ability to decredit a program, to say your residency program is not following our guidelines, so we're going to take away your credentials, destroying your program. I'm in Texas. I know our Attorney General is very upset about this issue because here in Texas, we're trying to protect unborn life, and yet we're having to take our state tax dollars to send the obstetric residents in the state out of state to get abortion training because of this mandate. So who knows where this will go, but it really is a legal conundrum that it should not be happening, and yet somehow the ACGME as a private organization is forcing it to happen and forcing this training.
So when you think about where we all practice, where training occurs, there are a variety of academic institutions, and some of them are religious institutions and hospitals that practice life-affirming medicine. So how are they navigating having to have this complex family planning specialty?
Well, I think it's a problem. I don't know personally how these Catholic and other faith-based residency programs are dealing with this, but we can see that things are going to come to a head because they're not going to violate their own conscience as an institution or the conscience of their residents to force this. So what does that mean? Does that mean these programs will be forced to cease to exist? And if they cease to exist, the Affordable Care Act mandates that those residency slots must go elsewhere. Where will they go? They will go to a pro-abortion program. So again, we can see so many ways that this complex family planning and all the actions that have led up to it are weaning out the pro-life doctors, the doctors that are willing to fight for both of their patients, and stacking the deck so that it's only pro-abortion programs. If a resident comes in and maybe doesn't have a strong opinion, the pressure is going to push him toward performing abortions, providing abortions in his practice, becoming an abortion advocate because of all of this biased training that they're receiving. So it's very, very concerning for the future of our profession, for the ability to train doctors who value life.
You know, you referenced a survey about what percentage of OBGYNs actually perform induced abortions. And, you know, I think there have been about 3 studies, maybe even more now, that really show that a small minority of OBGYNs have induced abortion as part of their practice. I always think about the cognitive dissonance it would take to walk into a room and be really excited, maybe with a couple who've experienced infertility, that they have a positive pregnancy test, and then go in the very next room and write a prescription for mifepristone and misoprostol to end that person's life, where in one room that fetal patient is going to be receiving health care, and in the next room you're going to end that fetal patient's life. It really doesn't make sense, which is why so few of us do it. I call that group, those of us who are not doing it, which is the majority of OBGYNs, the sleeping giant in this movement. I feel like with that long march, we lost kind of our profession. And I think a lot of the chaos and confusion post-Dobbs has actually come internally from our own profession, confusing the public. What do you want to say to that sleeping giant out there, that really busy OBGYN who is working hard, taking care of both patients, but unlike you and me, who are kind of more involved in the at a board level and seeing things at a state and federal level, what do you want to say to them? How do we need them as a profession?
Well, I recognize that it's hard. You know, years of private practice, you don't think about the issue. You really don't. And of course, it's hard to find good information. And so all of this is happening really outside the recognition of the average obstetrician. I think probably many of them are not even aware of the harms that mifepristone and misoprostol abortions are doing to women. How many are showing up in the emergency room, pretending it's a miscarriage, getting suboptimal care? I mean, there's just women really being harmed. So it certainly can be corrected. I think even as the corollary is what has happened in our universities. And Americans are wide awake right now to the fact that the universities have become brainwashing institutions for their children. And there is a major outcry against that. And I believe that can happen in OBGYN as well. I think anybody who's watching this, if you're not familiar with APLOG, please find out what we're doing, support our mission. On the flip side, I'm still a member of ACOG. Many of us are. We need to make our voices loud with ACOG and ABOG and these other organizations that say they represent us, when in fact they don't. In fact, they have never, in the 30 years that I've been a member, they have never surveyed their membership. What do you think about all our abortion advocacy? So they give the false illusion that they represent doctors who feel like they do, when in fact, I believe it's only an extremely small minority of the leadership that are driving this agenda. So we need to speak up to ACOG. Our patients need to speak up to their doctors. I think if many pro-life women would tell their doctor, hey, are you aware that ACOG has said there is no permissible limit on abortion, that there is no circumstance where there should ever be a limit? I mean, it's our fault in a way that we've allowed ourselves to be led by an organization in which the leadership is so corrupt and is working antagonistically against what we all want to do, and that's to provide high quality care for a mother and her unborn child.
Thank you for that, and thank you for joining us today. I think that's a great way to close and to just simply remind OBGYNs that we do take care of two patients, and that fetal patient, that baby, doesn't become a patient by a decision. Science shows, embryology shows, it's a human being at sperm egg fusion, and then we have to, as you suggested, step out and let our voices be known. And I totally agree with you that I think it's going to be our patients, our moms, our dads who are with them, who are out there, who want to protect their babies, and they're going to actually push back on the nonstop assumption that the value of their child's life is so minimal. Rather, the value is inherent, and those babies that, especially the sick little ones that have those life-limiting diagnoses, we don't need to take less care of them. We need to take better care of them because they're really sick. And so we're so delighted that you joined us today. And I also want to thank all our listeners for joining us. And so if you find this content helpful, we really invite you to support our work by joining AppLog if you're a medical professional. And if you're not a medical professional, but you care about ensuring accurate medical information is out there, and you want pro-life doctors to be able to go to, consider donating at applog.org. So also, if you like this episode, be sure to give us a like and subscribe on YouTube. And if you're listening by a podcast app, we'd love a 5-star review. So we'll see you on our next episode. Everybody have a great day, and thank you again, Dr. Skop.
Thank you, Susan. It's been great.